Yes, good morning and thank you to having me here. I didn't had a long travel because I work in Amsterdam for a service provider here, and I'm one of the coordinators indeed of the newly renewed Correlation Network, which is now called the European Harm Reduction Network. So I want to talk to you about drug consumption rooms, but then in the relation how those facilities address HCV, because we are on the AIDS conference and it is not a general presentation on what are drug consumption rooms. However, you find a lot of materials and also extended surveys about that on our website. So today I speak about how drug consumption rooms address HCV. And it is in close collaboration with Sydney Medically Supervised Injection Center. They call it like that, and we in Europe usually call these facilities drug consumption rooms for different reasons. The Sydney consumption room, however, is the first one in the southern hemisphere, in the Anglo-Saxon world, and was already established in 2001. And as all drug consumption rooms, they aim to reduce death and injury from drug overdose and reduce harm associated with injecting drug use. They have an amazing crowd of people visiting the facilities, with more than 1 million visits and more than 16,000 registered clients. In all those years, they not had at all one fatal overdose. And of course, they could refer a lot of people to other health-related services, so more than 30,000, and they managed to handle overdoses in more than 7,500 cases. So really, that is a very impressive numbers. Our drug consumption rooms, which are not run by our Correlation Network, but Correlation Network is a part of is the international unit of the Regenboog Group in Amsterdam. We run 4 drug consumption rooms, and I will talk a little bit about that later. However, the Correlation Network was launched in 2004. We have 4 major pillars: networking, monitoring from the viewpoint of civil society, and capacity building advocacy, and we do a lot of work on hepatitis C, overdose prevention, drug consumption rooms, and new drug trends, and civil society involvement in drug policy as an overall issue is very important to us. At the same time, we also host the International Network of Drug Consumption Rooms. That is an initiative to bring all these rooms together. Currently, we have around, and this is an increasing number, luckily, because mostly in Canada, we saw a lot of openings of the facilities. However, when we did our surveys, we addressed 91 rooms, and the network is obviously there to sharing best practices, to work together on common guidelines, to to have exchange visits, and so on. So everything around drug consumption rooms you can find also on the specific website of the international network. When it comes to drug consumption rooms and hepatitis C, we all know that hepatitis C is a major problem for people who use drugs, and the prevalence rates are extremely high, with up to 80–90% also in European countries. There is almost no research on specific HCV prevention treatment in those DCRs. However, what we found, for example, in Germany, was a prevalence of 63% under visitors on drug consumption rooms, and, for example, 43% in Spain. Both countries have a relevant number of drug consumption rooms. And as we know, at the same time, we have a dramatically improved cure opportunities for HCV with the new direct-acting antiviral agents, the DAAs. At the same time, we have a lot of improved technologies, testing methods, to really be able to test people in low threshold centers, in drug consumption rooms, in harm reduction service, and so on, and even to treat them. If regulations and the health system allows, you could easily treat people in low threshold facilities. So that makes it, from our point of view, so interesting to look into what drug consumption rooms could do in this respect. So our questions in regard of that was what is the range of HCV services currently offered at DCRs, what are the operational capacities to do so, what are the factors associated with HCV service in DCRs, and what are the needs and resources requirements which would be needed to improve or increase those designs. So we asked the DCR managers for a 30-minute questionnaire. No question was obligatory, but if less than 50% of answers were missing, we excluded them. And that is the overview. Once again, here you see the countries with the most rooms, with the Netherlands, Switzerland, Germany, and Spain, which have, for example, in Spain, you have 15 rooms, but they are concentrated in the Catalan area and in Bilbao, so you can't speak at all over coverage in the country. Even in Germany, you have only a couple of parts which are covered by consumption rooms, and the Netherlands have a quite balanced coverage, you could say, and also Switzerland. And the remaining countries, unfortunately, only have a few of those. So Australia, Canada in those years had only one. I think there are now more than 10, so that is really an absolutely very positive development in that regard. In France, we have 2. Considering that France was always a very conservative country, at least that is a landmark, and at least that is something, it gives a message, but 2, of course, is not fit at all to the needs. Denmark has a quite good number with 6, Norway and Luxembourg completes the picture. So we looked into how these rooms, the drug consumption, are organized. Most of them are run by NGOs or by local or central government. For example, in Amsterdam, we also have drug consumption was the municipal health service. A couple of them are private, and also a church was involved. Most of the rooms are co-located with other services. That means that they are in a cascade of care of integrated in services, but we also have a couple of those standing alone facilities, and very important also a couple of mobile services, which is really in a way cost effective. You can reach neighborhoods where other ways no facility could be established. So that is a very important measure to have. And in average, the size of those rooms, it's about 12 places, and let's skip this sheet. We also asked who is included in DCR staff. So we see that 80% of DCR staff have a nurse, they have social workers, and to less extent, they have a medical doctor, health educators, and at least 21% have also paid peers in a paid position, which we think is a very effective and useful tool to have, and we would like to see that this number is increasing in the future. What services are provided on-site by drug consumption rooms? So almost all are referred to care and other treatment facilities. So also here you can see drug consumption room is not a self-standing measure, but it is an integrated part of harm reduction and other treatment services. Obviously, they distribute needles also for takeaway. They provide condoms, and they have overdose management, but of course, it is very obvious that they do having this task. So HIV testing is carried out by more than half of them, outpatient counseling, mental health care, take-home naloxone provision, and so on. And in case this takes not place on the spot, at least they can refer to elsewhere, which is the second best opportunity, but it is one. So what are in regard of HCV services they are involved in? So 94% of the rooms offer HCV-related education. That is basically safe use education about transmission routes, about testing symptoms, treatment options, and they do that by brochures, pamphlets, individual client consultation, posters, and to less extent to digital resources, educational campaigns, or also group education sessions. But what you can see, most of those have awareness on HCV, which is very effective in order to tackle this disease. What they do on HCV and support services. So most of the consumptions are able to refer to other services for HCV treatment or also planning to event. They have on the spot disease self-management support, speaking about to counsel and to speak to people about healthy diets and obesity and so on and so on. And also a few of those have liver health monitoring assessments, which is already a quite advanced measure in this area. In regard of the new treatment options, this is not at all developed right now. We found 2 rooms who on-site could offer HCV treatments with the new DAAs. It is really very important that we can see it is possible, but in the future we would really argue and advocate to increase that number dramatically. So what factors associated with HCV testing on-site? So what we found out is that if DCRs provide HCV testing on-site, they obviously were significantly more likely also to provide HIV testing and HCV vaccination. So that is with a factor of 44 that HIV testing is offered in case of testing anyway. And if DCRs employ a nurse, it is also very obvious that they also provide other medical services. This is really significant, but for me also not really a surprising outcome. And the same takes place with if people have HCV disease management, they employ a medical doctor or they provide opioid treatment. So all this is linked with each other, and again that says that drug consumption rooms can provide a range of health services and not only facilitates safe injection. What would be needed to increase these capacities? So the most answers were that they would employ additional medical staff and spend more time on training, which obviously and is a very important measure in order to increase the capacity and finally the service provision. They would also fund additional materials, and they would employ peer support workers or improve the referral pathways to specialists. Now, and to finalize my presentation, I would go a little bit more to demonstrate the practical impact and to demonstrate the case study. And our colleagues from Sydney provided me with these sheets. So, as you might know, Australia have a really amazing HCV elimination program. They will spend $1 billion Australian dollars in the next 4 years, or they started in 2016, so it's 3 years left, on HCV treatment with a barrier-free treatment also for people who use drugs. And in case they include more people and costs would rising, pharma industry committed themselves to cover these costs. So that is really an amazing concept. At the same time, as I said before, the drug consumption rooms, these 2,000 people a year, which are not in contact with, I would avoid to speak about hard to reach, but which are not in contact with regular health services. That means that the colleagues in Sydney need to refer people to other clinics. They have reliable collaborations on that. However, it is not that they can do that in their own facility, and that is a disadvantage. So they are allowed to administer particular treatment options, but not for HCVs. So they have to mediate them to this clinic, and this appears still is a problem for many people. That still is a problem to go to another spot, and there's quite a lot of dropout on that. So that needed to be changed, but let me explain you one case that is a man in the 30s with a long history of injecting and street-based homelessness, over 15 years HCV positive, and the experience showed that the adherence to any medical treatment options is very low. At the same time, this person has an uncontrolled epilepsy with 2 to 3 times attacks a week. So that here again, it was a big problem that adherence was very low. So the only service he engaged was the drug consumption room, and which he attends 2 or 3 times a day. So it should be the best solution anyway to do everything in terms of medication in this facility. So they managed in first instance to get the epilepsy medication to the room, and for him to bring him for him to self-administer this medication. And they also linked him to HCV testing. So then they could make an agreement with the pharmacy and with the health authorities that also the DAA treatment was included in this package specifically arranged for this person. And since then, the results are very, very positive, and he has cleared HCV after 3 months, and he also was able to follow his obligations and to follow his treatment. So that is really a very impressive example how it would work and how we would overcome all the barriers in regard of HCV treatment in low threshold centers. And that is something what we really want to see much more in regard of harm reduction and hepatitis. Thank you.